Welcome to BeeWellwithMS podcast series where I and expert guests discuss science and science-based tools for everyday life to preserve brain health and quality of life living with MS. I'm Dr. Agnes Trokiana, neurologist, researcher, innovator at Torbay and South Devon NHS Foundation Trust in the UK. So today's guest is Dr. Antonio Scalfari. He's a consultant neurologist at the Tertiary Centre for the Management of MS and Neuro-inflammatory Diseases at Imperial College Healthcare Trust, Charing Cross and St Mary Hospitals, and at the Neurology Department of Northwest London Healthcare Trust. He also runs his private neurology practice in London. He's done his research as a research fellow at Oxford University from 2003 to 2006. He has also completed his PhD in neuroepidemiology, and then he has done 2 years postdoc clinical fellowship at Imperial College London. He's an Honorary Senior Clinical Lecturer at Imperial College London, where he contributes to the teaching activities for medical students. His main research interest is in multiple sclerosis epidemiology and prognostic factors. He has authored several scientific articles in highly impact journals, and he also participates often as a speaker at international conferences and webinars and seminars in MS. He continues his research activity in collaboration with other international academic organizations. Antonio is one of the first neurologists in the world who has dedicated his time researching the prognostic factors of progression in MS, and he's discovering that process of natural progression of MS is independent of MS relapses. There is something more that drives the natural MS progression, and he introduces the concept of smouldering MS. He has recently published that, and we will talk about this later. He's also investigating the impact of aging process on MS brain health. In this episode, we are going to cover the topics such as premature, early process of aging, living with multiple sclerosis. What are the steps and tools to implement to slow down the aging process? I know we all age and that's so unfortunate, but there are some ways to slow down the process. And it's super important if you have MS and you live with MS. The brain health is very important, and how to preserve the brain health we will tackle during this discussion. So welcome to the show, Dr. Antonio Scalfari.
Agnes, thank you for having me with you, and thank you for a very nice, extensive introduction. Thank you so much. How are you?
Good, very busy as always, and thanks for being here. Thanks for coming. So, Antonio, I always ask my guests about, what does that brain health means to you personally? Take me through your healthy daily routine.
Well, brain health means like protecting our most precious organ, right? The brain, irreplaceable compared to many other organs in our body. So we need to make sure that we do our best to preserve it cognitively and functionally. What do I personally do? I think one essential point of daily activity is keep yourself cognitively active. So learning on a daily basis is the best way to maintain fitness of your cognitive function. I must give the example of my 98 years old grandma, who still does, she has been doing since the age of 18 crossword, and she still remains very much cognitively intact. And I do believe strongly that because she has been doing for all her life on a weekly basis crossword, this is contributing to her brain health.
Wonderful. So I think keeping our brain active is giving a task for the brain to do. We can't just sit and do nothing. I think the way we are built in this world is to handle the tasks, handle the challenges, have something to do, and that's how you keep your brain active. So talking about something that is unavoidable, unfortunately, is that we all age. It's the process. We naturally phenotype, the way we look like is changing over the time. The way we feel, the energy level, everything is just a pure dynamic. But just a question, from my point of view is aging as an aging process is a disease, and can we biohack aging process to improve their longevity, and how can we do that?
is aging a disease? It's an interesting question. Once I heard someone defining life like a sexually transmitted disease with 100% rate of mortality. So in that context, aging could be seen as a disease, but it is actually not. I think it's a natural process that involves everyone and in a different way. Longevity can be part of life for many individuals. There's so many factors involved, and I think the key of longevity yet has to be fully explained and still on the way is being explored. I mean, there are arguments whether this could be related to some genetic differences among individuals. And there's been some recent work, I think, about specific genes that can explain longevity. Some people, depending on the geographic area where they live, they tend to live longer, whether this is due to specific environmental factor or whether because they belong to certain group with specific diet. It remains to be established and elucidated. Some people believe the classic Mediterranean diet can help improving longevity because of the longer life on average in individual living in the Mediterranean area. But also we see a lot of individual like with a very long lifespan in Japan, for instance, again bringing back the subject of diet. So it's a very complicated subject. I mean, it's fascinating, but still a lot to be elucidated.
So what the Sardinians people do to live long lives?
Well, I think it's not only the Sardinia, it's all the Mediterranean. There's also the Sicilian, where I come from. The longevity. I think all the Mediterranean, also the Greek island. It's a healthy lifestyle, probably less stress. They tend to avoid the deleterious effect of stress. Vitamin D, could that be the key? Could be like the longer sun exposure, higher vitamin D in the general population. Whether that could play a role, I don't know. And then genetic, of course, that can play a fundamental role. But the role of gene needs to be established yet, and they are just suggesting so far.
So is it something that we are born with? And it's coded that we're going to die at a certain age, or it's something that we influence by choices and the place where we live and exposure of the vitamin D. How does that work in general? Is it something that combination of things?
I think I think it's mostly a combination. Sometimes I do question myself whether we are born to last up to a certain point. And then apply the same question to my MS patients. Are people just born destined to have MS? So is MS like an acquired disease, something that you acquire in life, or you are destined to have it anyway because it's there somehow with a genetic predisposition? It's always a question that fascinates me. And of course, it's a bit of both. Then there is environment implicated. So how the environment that can change your genetic is the so-called subject of epigenetic, right? There's these theories according to which like environmental factor can then modify your genetic and therefore expose you to a certain risk of developing certain diseases such as MS, or maybe expose you to an higher risk of aging more prematurely compared to the average individual. It remains a big open research field.
That's interesting. And there is one of the researchers, David Sinclair, that proposed a radical new theory of aging. So David Sinclair, one of the researchers he's investigating the longevity, and he proposed a radical new theory of aging that's suggesting that aging hallmarks are symptoms of epigenetic changes that occur over the time, but the original genetic code remains very much intact. So this is just supplementing and what you just said, Antonio. I think that really everything is I think there is a role of the genes that plays in our aging process, but also the environmental impact on our well-being. And I think one of the most common changes in aging skeletal muscle loss in our bodies. It's a major reduction in muscle mass, ranging from 25 to 45%. And there is a condition which we call sarcopenia of old age. It's defined as both low muscle mass or low muscle function. So sarcopenia develops in the normal aging process, and also can develop.
I think after the age of 40, you start losing muscle bulk.
Yeah.
As a natural process.
Yeah. And it's also, it's a sort of a secondary to medical conditions can also be, such as arthritis can influence the way people age a little bit more rapidly. And among various different risk factors, oxidative stress on the muscle has been suggested to play a critical role in sarcopenia. And also, there is a research question of how uremic acid affects the sarcopenia. So this one of the sort of antioxidants, very strong antioxidants in our body, that is responsible of the sarcopenia. So it can have a very detrimental effect as a pro-oxidant. If it is too much, it can be harmful. If it is too low, also it's not good. So the level of the uremic acid is good for maintaining the strength in our bodies. So in particular, the grip weakness, I would like to focus that some of the research that came out recently suggests that it's one of the early signs of aging process, as well as the skin changes and sensory changes in the hands and limbs. Grip strength has been proposed as a biomarker. Supporting this evidence is provided that grip strength is largely consistent of the overall strength. So that makes me think, could it be used as a sort of a predictor marker, predicting the aging process and the muscle loss and sort of sarcopenia in the long run? There is a link between the whole muscles in the body.
I think also walking, somehow, although it's difficult to be assessed in addition to the grip strength, can be a marker of aging. Grip weakness, it's interesting, that can be considered a marker of aging. And I think also the walking, the impairment, is also a potential marker of aging. And when we discuss MS cases with some colleagues, we always take into consideration that somehow the effect of aging affect our neurological evaluation. So we always say by joke that the EDSS score that we use in assessing MS patients naturally progress with aging. So a patient growing older eventually will have some changes in the EDSS score which are not necessarily related to the MS itself, but as a part of the natural aging process.
It's really very interesting, and I think also what I figured out from the literature, that there is evidence as grip weakness, and it could work and play the role as predictive link between all causes and disease-specific mortality, future function, bone mineral density, fractures, cognition, depression, and all the associated hospitalization. So it's really could be an emerging biomarker that potentially we could use in our research as an early sign of aging and to evaluate the function.
The problem is, even if we establish a link with the aging process, we still don't know how to prevent the aging process. And that's an important area that needs a better understanding. How we can monitor, we learn how to monitor aging, but then how can we just affect the process? How can we slow it down? And so that's another interesting aspect of the aging process itself.
So biohacking your aging process, so changing epigenetics, implementing healthy living, healthy lifestyle, living on the coast of the Mediterranean Sea, and hoping for the best.
Move to the south of Europe.
I think this is what we need to do. So wonderful. Right. So moving on to MS more field and MS topics. So let's talk about MS and aging in particular. And what is the current evidence of peak age to develop MS these days? It used to be 40 years old. Now I'm seeing patients in their 60s, 70s. What do we know currently? Is it becoming an elderly people disease? Is it something that we don't know as yet, or there is in general delay in diagnosis that we see people later in their disease trajectory?
I think traditionally, historically, MS has always been considered presenting in between the age of 30 and 40 on average, but the spectrum of the age at onset presentation is widening a lot. It's widening on both extremes. We are seeing much more pediatric cases as well as much more late onset MS cases. I mean, I just read recently the MS Atlas survey, which was published like a couple of years ago. There's been a massive increase of number of pediatric cases that have been detected since 2013 on the previous MS Atlas survey. Like an increase like 30% more compared to what it was originally reported worldwide. And the same can be said on the late onset MS. There are beautiful data from Norway cohort. They have access to a comprehensive cohort of patients covering basically all the MS cases in Norway. And they reported an increased incidence of MS, especially after the age of 50. Very interestingly. So the depending question is whether this is a true increased incidence those age categories, or potentially, therefore, we can start speculating about the role of environment. Who knows? We can consider many different potential factors that affect this increased incidence in the older population. But also the other factor to be taken into consideration is obviously the access to a better diagnostic tool. Once upon a time, MRI was difficult to be implemented, was not available readily. Nowadays, much more commonly used. We do MRI for any reason. There's a much higher number of patients with radiologically isolated syndrome because we do an MRI for any reason, any finger numbness, you do an MRI. So that could probably, to some extent, also explain why we do see much more cases of MS in late onset, but and the shape of the age spectrum of the disease is widening for sure. Is changing. So we can't say simply MS is a middle-age disease. It's also definitely a pediatric disease and a disease that affects people in the older age for sure.
I can only agree with that, and I think what is important here that I think the whole prevalence of our Western lifestyle, a lot of pro-inflammation in our bodies, stress, changes of epigenetics. I think that overall the prevalence of autoimmune diseases is quite high, and I think that prevalence of MS is growing exponentially every single year. So I can see that as a reflection at my MS service that each year we've got a 10% increment of the number of newly diagnosed people with MS. So I think that resembles elsewhere nationally and globally. And because of the enhanced numbers, so we have a more variability in terms of an age within the category of people who develop MS. It's variable. So I think that probably reflects, and there is a correlation between the age when people are getting diagnosis, how many people are getting diagnosed. I think more people are getting variety of people are of age groups are developing MS. So that's probably a reflection of that.
Yeah, no, what I want to add, I think you raised a very important point because the widening of the age spectrum in MS is posing new challenges for the MS services because we are dealing with larger number of patients in pediatric age, and that goes into diagnostic difficulties, differential diagnosis with a lot of other neuro-inflammatory disorders typically observed at young age. And on the opposite side of the spectrum, we're looking also at other different challenges, also diagnostic among older people, which can be exposed to other types of disease, potentially contributing also to overlapping the neuro-inflammatory disorders. So we have to learn more to adapt ourselves to this changing epidemiology of the disease. And I can tell you that the ACTRIMS committee I was recently involved into, we are focusing on this specific topic, on the challenge of MS at the extreme of the age spectrum. So it's a topic that is attracting a lot of interest at the moment.
Because it's very interesting, because we never consider it, and I think you're the first neurologist who published a lot of research around the aging process and the natural process of pathogenesis and progression as well, and how the aging process impacts on MS. So if you would like to read more, so please Google Dr. Antonio Scalfari online, and you could search for his papers and research and explore in more detail his work. What happens, Antonio, when MS brain ages? Is it is more that premature process in contrast to healthy population? What happens when people with MS age sooner in contrast to normal population, and why is that?
Well, it is interesting. I think age can contribute to MS progression in different way. By aging, we lose reserve capacity. That's a known process. We know that happens naturally and physiologically. And if that's overlapped the pathological process that occur in MS, the loss of reserve capacity is further and more rapidly lost. That's how I see aging process like eventually contributing to the MS progression. So in a way, we have an accelerated aging of the brain, which contributes to the so-called end of organ damage, which is classically mirrored by the so-called brain atrophy. So in a way, the aging process among MS patients is accelerated because of the double contribution of the MS pathological process and the physiological aging. It is interesting, there is a publication which I found very, very enlightening, whereby they try to distinguish and dichotomize the effect of natural aging from the effect of MS on the brain atrophy. And they came up with these data saying that up to the age of 60, MS-related brain atrophy is the leading driver of the brain atrophy itself. But after the age of 60, it is the natural aging that takes over, and irrespective of the MS pathological process. So they came out with this sort of age cutoff, after which basically MS-related process do not contribute as much as the aging process. I think those are data that need to be replicated, but the bottom line is that we have a contribution of both natural aging and MS pathological process that eventually results in a gradual enhanced reduction of the brain capacity, reserve capacity, and therefore the brain becomes less able to abate the damage and therefore is more exposed to premature aging as a result of that.
So it almost feels like there is a combination of a process that is part of the MS, that you get a brain atrophy, a loss of the volume of the brain, but then it tops up with a sort of a natural aging process, and it almost feels like people with MS, they have got a double whammy of the sort of a process that is part of the aging, plus the immune condition that drives this pathogenesis and neurodegenerative process that indicates and then as a consequence leaves with a brain atrophy. If you combine these two together, so I guess that's the reason why we're talking today is to think about the strategies. How can we reverse and slow down the process of aging and take the impact at least 1/3 from the brain health and leave the patients just with a sort of having just MS as a disease, or it already is a catastrophic process to the brain health. You know, if we could modify the natural aging process, we probably could take away an edge from sort of losing the brain cells. And I think that's what we see in our clinics. People who are fit, they run, they walk, they do various different physical activities. They have good resilience to stresses around. They know how to cope with that. It's an unavoidable situation for everyone's lives. When they sleep well, when they eat well, the whole process feels to be a bit mild in general. And we all, as neurologists, we see that in our clinics. Do you agree, Antonio, that there are some category of patients, and people who smoke, who drink alcohol excessively, who eat processed, ultra processed, ready to go meals. They look older, they feel older, they have multiple more symptoms, they're cognitively impaired.
Yes, I fully agree. You highlighted all the potential modifiable factors that contribute to an accelerated aging. A big proportion of those factors is related to vascular risk factor, of course, and that has been shown to be an important driver of MS progression because of the additional damage of the brain tissue related to the vascular damage. So avoiding the developing vascular risk factor by exercising regularly, avoiding smoking, having a healthy diet that prevents hypercholesterolemia, keeping your blood pressure at good control, that all contributes to avoiding an additional chronic vascular damage that would have a deleterious effect on already impaired brain because of the ongoing MS pathological process. Mm-hmm. This is certainly some aspect that patients can focus on and can by modifying their lifestyle and therefore preventing any unnecessary additional progression of the disease, which can be avoided.
Yeah. You avoid the burden on the disease by modifying your lifestyle. That's very important. What about the immune cells? Are they age too? Let's talk about the immunosenescence process of the immune system. What is it, Antonio? If you could take us through a little bit and explain it a bit in more detail.
It's cells age, and that's a microscopic level what happens in the general aging process. And the senescence of different type cells can somehow contribute to MS progression. It has been demonstrated that senescence of the endothelial cells and the astrocytes are probably involved into further disruption of the blood-brain barrier, and this can further contribute to the damage in the MS brain. We also know that aged microglia and macrophages impair the clearance of the disrupted myelin and therefore would affect the so-called remyelination efficiency, therefore the reparatory mechanism. We also know that the T cells can age, so they can become senescent. And when they do so, there's an enhanced release of pro-inflammatory cytokines, which can further aggravate the neuro-inflammatory process. And a big focus of research has been on the failure of remyelination process. There's a lot of focus on potentially finding therapeutic compounds that can somehow enhance remyelination, which is a natural process that occurs. But, of course, remyelination is also an age-related process. Unfortunately, remyelination failure has been demonstrated in experimental models, whereby they found that older animal models have much less capacity to remyelinate compared to younger animals, and therefore that applies to individuals. So that's definitely going to be one of the future target of therapies to try to repair damage that occur as a result of the pathological process of MS.
Yeah. So we just need to be, as a patients need to be aware that with the aging process, the function of the cells to repair is slightly impaired when you age, and it affects the cells in the bloodstream and the lymphoid organs, and it can lead to changes in the immune function of the elderly. And so people with reduced repair of the immune cells, they tend to develop more viral infections, they tend to have more malignant tumors, other autoimmune diseases, and that's something that we need to take into consideration when we think about it. Again, we're going back towards how to biohack the aging process to help cells to repair and to produce more myelin, to remyelinate the nerves and to improve the function overall. Antonio, moving on, I would like to talk about some studies suggest that lower disease activity is seen with older age in MS. Is that true? And then how does that impact on our disease-modifying therapy choices. Should we stop disease-modifying therapies in all the stable neurologically MS patients or not?
Well, that's a very interesting and relevant question. I still don't have an answer. And I think in my clinical practice, I do take decision on a case-to-case basis. I cannot have a general rule. As you mentioned, the inflammatory disease activity, which manifests with new inflammatory attack, the so-called relapses, as well as the occurrence of new lesions on the MRI, is strongly age-dependent. So we know that as a part of the natural course of MS, the frequency of inflammatory attack or relapses and the occurrence of new lesions tend to decrease with age, and it becomes much less frequent and more sporadic during older age. Is that true that we should therefore stop using treatment, given that there's not going to be any further target for those treatments in old age? It remains a pending question. On the other side of the argument, you can say that with advancing age, if patients do have a relapse, they have less ability of recovering from the relapse itself, probably because of the pathological process age-related that we just discussed, related to the failure of reparatory compensatory mechanisms. So we might argue on one side, okay, we should stop the drug. They don't do much help at one point after a certain age. But if patients end up having a relapse, then the patient is going to have less chance to recover from that specific relapse. So probably in principle, it's better to try to prevent that relapse from happening at the beginning. It remains a huge controversial topic. I think there are a lot of studies, sub-analysis from trials that have shown that the efficacy of the currently used disease-modifying treatment seems to gradually decrease after a certain age. One of the biggest meta-analyses that been published came up with this age threshold of 55, after which DMT shouldn't be used. But I think this remains hugely controversial, and I can tell you there is a very important study still currently ongoing in US, which is called DISCOM, and they're looking specifically at this topic: when to stop DMT, at which age we can confidently say we can stop it and nothing is going to happen to our patient.
Wonderful. Antonio, I'm sure that you are getting some referrals from your colleagues or primary care physicians who now read your publication about the Smouldering MS, and I would like to know a bit more about this concept in general. What is it, and why should we care about Smouldering MS in the modern times?
Well, the idea of Smouldering MS stems from the frustration of physicians seeing their patients in many cases getting worse despite successfully suppressing relapses and new activity on the MRI with our currently available therapies. And a common clinical scenario are patients whereby we know that the therapy is being successful according to classic inflammatory parameters. The patient is stable, according also to guidelines. We're not allowed to change treatment because we are hitting the therapeutic target. But yet, in clinic, patients refer to still not feeling well, getting slightly worse, describing subtle symptoms that goes beyond the classic relapses, or cannot even be categorized as the classic progression of the disease itself. But they are not happy. And so this underlying a wide umbrella pathological process that goes well beyond the focal inflammatory activity, which drives the occurrence of relapses in new MRI activity, and refers to a so-called smoldering process that determines globally a gradual deterioration and progression of the disease, which is completely independent from the focal inflammatory activity. And now we are giving part of this smoldering process is the so-called progression independent of relapsing activity, which is a new emerging concept, being shown to be a very important component of the disease progression. It occurs since the very early stage of the disease, and is bringing new emerging idea on the fact that MS has a progressive element, which is seemingly driven by smoldering process since the very beginning, while at the same time patients do have the classic relapses and inflammatory lesions and the MRI. So we came out with the idea of smoldering MS to highlight the importance of focusing our attention beyond relapses of focal inflammation, which now we are very good at suppressing with our therapy. So we need to see that beyond, try to identify new therapeutic target which contributes to the global smoldering disease, which is now a big unmet need and contributes tremendously to the gradual deterioration in our patients.
I think, Antonio, what you just said, this is the key message to our all listeners to understand better this condition is when you come to see neurologists in your clinics, they point out your scan results and shows the lesions in the brain, but you have to understand that there is more than just a lesion in the brain that you've just been told or showed on the screen. There is a diffuse inflammation within the brain structures in the meninges, diffuse elsewhere, not necessarily particular in the lesions. Choroid plexuses, which is the structure inside the huge chamber, which we call ventricular system. It's a lot of going on, and I think on the other side, I don't want smoldering MS to become, as a definition, overused in the MS community, because quite often, when we see patients and they complain of a lot of symptoms, we may say, well, you haven't got a relapse, you haven't got any changes on MRI scan, you've got smoldering MS then. Is it really, do we have a capacity to define objectively, to measure the smoldering lesions in the brain? I know that there were some attempts to use the PET scan. Can you comment about this, Antonio? How to objectivize smoldering, that we are not overusing this definition in our clinical practice?
I think we're still at the very beginning of this story, and we don't have an objective definition of smoldering MS. We don't know what exactly the pathological process behind smoldering MS are. There are a lot of good candidates, as you mentioned. Great, they're becoming increasingly popular, the so-called smoldering lesions or slowly expanding lesions, which are, I like to call them outlier lesions that, in contrast to what happened to vast majority of focal lesions, that shrinks. In contrast to this process, they tend to actually enlarge. So it is likely that these are potential pathological drivers of smoldering MS. Microglia activation is a new kids on the block, new therapeutic target for emerging therapies. Again, potentially contributing to smoldering chronic inflammation that can be part of the smoldering process. But I think I like to see smoldering MS like a much wider concept, an umbrella of mechanisms that still needs to be identified. Aging is part of it, I believe, with all the subcategories of the age-related pathological process.
Which involves the iron accumulation, right, and depletion.
Iron accumulation is part of it. Immunosenescence, senescent cells, as we discussed before, increasing vascular comorbidity, for sure. And so the bottom line here is the focus on smoldering MS aims at highlighting in the community the need of identifying new therapeutic targets. But we need as a starting process, we need to find a better definition, a more objective definition. We are working on it, actually, following the first publication. Now we're focusing on creating a consensus among experts on how to define the several sub-aspects of smoldering disease, and then having an agreement what are the pathological process and how to target that therapeutically. I think that's the bottom line of the smoldering story, which is in its very early stage. But one day we might say, in 10 years' time, 20 years, we managed to change the field, because at the beginning we started forcing the community to start focusing on something else. can't be satisfied by simply pressing relapses and new lesions on the MRI.
Wonderful. So when you decide to refer a patient to Dr. Scalfari, can you please consider twice about your referral reason about the Smouldering MS, and is it a reasonable referral or not? Because it's a lot of involved, and do we have tools to define that? I doubt in the day-to-day clinical practice, but that's something that is coming in the near future, and we will be equipped with better diagnostics, with better criteria what the Smouldering MS is, and then we will develop the targeted therapy to target the smouldering process within the brain structures. Antonio, what do you believe is true from your observation to preserve the brain health, even though you cannot prove it at this stage?
I think exercises would be proven to be playing a key relevant role in preserve brain health. And this is my always advice to all my patients. Doesn't matter what level of disability they have. Even in the most advanced disability, I always try say, be as active as you can. Don't push yourself too much, but don't stop. If you stop, the disease will take over. So I think that's the best advice I can give to my patients. And most of them, they receive this comment very positively, and they agree with me. Yes, I never stop. Even if I walk very slow with a trolley, I do my daily walk, I never stop. I don't put myself on the sofa and wait.
Wonderful. Antonio, for the listeners, there is the entire new podcast on exercise and the brain health. I interviewed Dr. Andrea Stennett. Please tune in and listen to that podcast. You will learn a lot of evidence-based advice and benefits to brain health living with multiple sclerosis. So, Antonio, I have a question. What have you changed your mind about MS management in the last year, and why?
Well, I think it's becoming evident that the current MS classification is not fit for purpose. It doesn't really reflect our clinical practice. So I do receive questions yet from my patients. Am I secondary progressive? Am I primary progressive? I always come up with, look, just forget about it. Don't worry. It's fine. It's becoming evident that we can't classify the disease that way. Perhaps we still have to classify the disease that way when we design clinical trials, but in our practice, I think what it matters is whether patients are having the certain specific target that we can modify with therapy. If they're having ongoing relapses or new inflammatory activity on the MRI, we try to target with our currently disease-modifying treatment. If not, we stay where we are, we just monitor. But I think I'm dropping this way of classifying patients, and definitely I see in the near future in the MS community dropping completely the use of SPMS, which I think is totally nonsense. Patients are progressive, primary, secondary, doesn't matter, or relapsing, or both.
Absolutely. As we discussed with Professor Gavin Giovannoni recently, it's at the end of the day, it's one disease, and it's very clear, and it become very clear over the years. And I think to start with, we need to update our McDonald's 2017 criteria, diagnostic criteria, and then move on in changing the classification, which we would probably, in the end, will call this condition as one disease, multiple sclerosis. Now, Antonio, we would like to challenge you a little bit. This is a question that comes from another previous guest. In this particular case, it was Professor Giovannoni, who asked the question to you. He didn't know who is he asking a question. That's sort of a trend that we've got in place at our podcast, just to keep the intrigue going. You will ask the question too in the end, but the question from Gavin Giovannoni during one of the podcasts I recorded on the comprehensive management in the 21st century, living with multiple sclerosis, he asked the question about the controversial evidence of intermittent fasting is there, and it has got some health benefits. So his question was, do you do intermittent fasting yourself? And if you do, what protocol do you use? And do you recommend that to your patients too?
As you say, there are controversial evidence about the benefit of intermittent fasting. I don't think there are evidence specific for MS, but there's been some relevant publication about benefit of intermittent fasting as a general health lifestyle. I don't use it myself. I always wonder whether I should. And in terms of regime, funny enough, I just saw a patient yesterday who just talked me about his own experience with intermittent fasting, and the way he's implementing this was quite extreme, but he said it's easy to be implemented. He said he would just have breakfast at 7 a.m., have a snack, a meal at 11 a.m., and then a snack at 3 p.m., and that's the end of it. And then he would have the next meal the 7 a.m. the day after. So that was quite a prolonged fasting. He's saying that he's feeling much better since he's been doing. He's not an MS patient, he's just having other neurological problems. I don't personally advise patients to do fasting, but sometimes they come to me and they ask what type of diet can be beneficial in MS. I don't have a straight answer, and I always say what is good to you, just do what you feel is good to you. Whether this is intermittent fasting, some people have mentioned the potential benefit of ketogenic diet as well. So the evidence are not there yet, but I think if it makes you feeling good, it's fine. That's what I do tend to say to my patients.
Yeah, for the listeners, there are different ways people try intermittent fasting, including the plans such as time-restricted eating. So you only eat within a set of number of hours each day. For instance, you might eat all your meals and snack over 12, 10 or 8 hours a day and fast the rest of the time. There is another scheme which is 5 out of 2, which means you eat normally 5 days a week and cut down to about 500 calories on the other 2 days. There is another one which is fasting mimicking diet. You eat very low calorie diet for a few days, followed by your normal diet. And alternate day fasting. You eat nothing one day and go back to your usual schedule the next. This is the most extreme method. And the last one is modified alternate day fasting. You vary between a normal calorie count one day and about 500 calories the next day. Some researchers note that Western style diet is linked to inflammation. And their theory is that intermittent fasting might bring down the inflammation and prevent the immune system from releasing chemicals that harm myelin. So that's sort of evidence that we've got. It's coming from the animal studies. As you know, the animal studies sometimes cannot resemble the human being studies. It doesn't apply to people. But some evidence in animal studies is emerging and resulted in better control of the animal diseases, usually it's encephalomyelitis in mice. These studies done only over a period of months. It's not a longitudinal, so it's unclear benefit and how it's going to remain for years is not known at this time moment. So until we know more, we need to wait. We can't recommend that to our patients, but some promising results are coming through. In general, intermittent fasting is considered safe, but it's not right for everyone. Skipping meals can cause blood sugar swings, so if you are living with diabetes, you have to be very careful, and there are some side effects like constipation, low energy, bad breath. You also need to make sure that you get all the nutrients you need whilst you're having intermittent fasting. So tune in and have a go and listen to the whole podcast on the diet in MS that I recently interviewed one of the nutritionists, Sam Josephs, and one of the former GP doctors, Colin Bannon. So, Antonio, it's time to ask a question to another Be Well with MS podcast guest on brain health. I won't tell you the guest's name just to keep the intrigue going.
To preserve brain health, would you advise all your patients, as soon as they are diagnosed, to undergo stem cell transplant?
Okay, thank you very much. And actually, this question is probably going to go to me because I'm doing some podcasts on comorbidity. So thanks for this question, Antonio. And to summarize and wrap everything, we discussed a lot of things today, and we understood that aging process is something that is unavoidable and we have to live with. It's a process of living with MS and having an aging process on the top of that. I think we need to be aware that there are factors influencing the speed of our aging process, and usually it's an environmental factor, which is mixed and combined with the genetics, which we call DNA. Is how we coded to live, and longevity is coded, but can be influenced very much by the environment. We also discuss about the grip weakness as possible biomarker to indicate the early starting process of aging process. We tackled a lot of around aging and living with multiple sclerosis. Is it more prevalent for people with MS having more premature aging process in contrast to healthy population? We also discuss about immunosenescence, which is an aging process of the immune function and immune cells and dysfunction to repair itself, to repair the myelin. We tackled the methods. How can we tackle myelination and demyelination? Are we still there to introduce agents to remyelinate? Probably not at this stage, but loads of investigations are around the pathogenesis and smouldering MS and what does that mean. We discuss all that in this short podcast. Thank you very much, Antonio, for attending today. I do appreciate for your time. It was such a great pleasure to interview you and share your knowledge with the community, share your extensive research information that you've gotten, and thanks for contributing to the research and being so active in the research field and running the clinics and providing the best care you can. I think you are on the same pathway as we all do, coming to talk for these podcasts that we all promote healthy lifestyle, healthy living, and these are modifiable factors contributing to brain health.
Thank you for having me.
Thanks.